We're just doing online. Hi everyone. So I think there are a few more people joining online, but we'll just get started. So thank you all for coming online and in person. So our speaker today is obviously online. And we've got Vittal Katikireddi, who is a professor at the University of Glasgow in health inequalities and public health, I believe. And Vittal's going to be talking to us about economic determinants of health inequalities and policy around this. So we'll save questions for the end. We'll have a bit of time for discussion. Vittal, whenever you're ready to start.
Excellent. Well, firstly, many apologies for not being able to join you in person. I'm afraid with a toddler who unfortunately has been unwell this morning. It's been a bit of a hectic morning, but delighted to at least be able to join you virtually. So hopefully, can you all hear me okay?
Yeah, we can hear you.
Yeah, great. Okay, so today I'm going to tell you a bit about the economic determinants of health, and given all of your interests in Bristol, I thought I'd try to maybe have a bit of a focus on causality in relation to the economic determinants of health. Obviously, as with a lot of these talks, I'm presenting the work of a huge number of other people, so many thanks to all of those people. Right, so in terms of what I'm going to try and cover today, I'm going to hopefully firstly suggest that the economic determinants of health are important. I'm then going to try to explain that actually it can be quite difficult to get a causality. And many approaches that we might use are subject to important limitations. And perhaps what we need to do is be slightly more nuanced in our approach at getting at causality. And some of the methods that we've tried to use, people in Bristol will be much more familiar with than I am, and others might be a slightly different approach. And then I'm going to try and finish off with giving you a bit of a flavour of how we might try to apply any evidence to the kind of world of policy, in particular thinking about policy modelling. I'll give you a few examples of work on those areas. Okay, so a quick recap, and apologies, this is probably going to be a bit basic for many of you, but why am I, as a person coming from a public health background, so I'm a public health doctor for part of my time, why am I interested in the economic determinants of health? Well, partly because in public health, we've got a long tradition of trying to improve health through the organised efforts of society. So trying to actually harness, if you like, the social machinery in which people live to try to improve health. And that can be a really important way of trying to improve health, and arguably perhaps more important than what we do within healthcare and health systems. So often when we look at mortality-based outcomes, for example, they're often more strongly related to the types of policies and interventions that we do outside of healthcare than what we're doing within healthcare. As a little illustration of this, if you look at government investment in different areas, so there's often a stronger relationship seen by with investment in social welfare than, for example, with healthcare. And then more locally, I'm sure that many of you are unfortunately getting very familiar with the issues around the cost of living crisis. And that's perhaps the most stark way we might think of the economic determinants of health impacting on on people's health, and especially amongst children. So while this particular talk, I'm not going to focus too much on children, you can see that especially child poverty is likely to have very substantial impacts on health, both in terms of having the necessities of life, but also potentially shaping future educational and other opportunities that then have lifelong health consequences. However, when we come to think about adulthood, so I'm sure you'll all be aware that there's a very strong association that's seen between income and health when you look at that cross-sectionally. Having said that, actually, the evidence base for there being a causal relationship between income and health amongst adults is much less clear-cut. So why might there be an effect of income on, for example, mental health? And often we've been focused quite a lot on mental health to start with, partly because it's a much more responsive health outcome than some other health outcomes. But we have been looking at other health outcomes as well. But if you change someone's income, you might think that that might affect their ability to have food, shelter, and also allow people to make decisions about leisure and having a good job and so forth. It can also affect people's feelings of stress, and it might affect health-related behaviors and so forth. So all of these things might then impact ultimately on mental health, but also potentially other health outcomes. As with many areas of studying health, we're often concerned about reverse causation, so the potential for poor health then to result in a reduction in income. And all of these effects might differ depending on the type of income change, but also who is affected by an income change and the type of society that a person lives within. So to try and understand a bit about the effects of a change in income, so trying to get a bit closer to causality, so we did a big systematic review. So looking at screening over 14,000 studies and so forth, and ended up with, I think, around 85, 86 studies within a meta-analysis, and a chunk more within a synthesis without meta-analysis. And what we saw was that for people who were being moved into and out of poverty, there seemed to be reasonable sized effects on poor mental health, and especially on well-being. But when we were looking at other types of income changes, the size of the effect was much smaller. So it appeared to us from the existing evidence that actually, if you get people out of poverty, that probably does have a health impact. Often quite a bit smaller than maybe the conventional public health wisdom, but it certainly seems to be there. Whereas when you're just increasing people's income more generally, so not necessarily at the lower end of the scale, in other words, that probably doesn't have a big health impact. But the reality is, looking at changes in income includes a very kind of wide-ranging set of things. And just like any intervention, trying to understand the nuances of actually what's being implemented is really important. So you can see in these three pictures, these are all pictures of cycle lanes, so bike lanes, but they're clearly very different in terms of the nature of them and what you might anticipate their impacts being in terms of how likely people are to use them, their impact on engagement with cycling and so forth. And in a similar way, actually, income itself is a really messy variable. So there's all sorts of choices about how we measure and define income. So are we interested in individual income or household income? Are we interested in income at a specific point in time, and over what level of time? Is it someone's income in a week, in a month, etc.? There's also very closely related exposures that are sometimes even defined in terms of income. So I've used the word poverty a few times. So a very typical definition of poverty would be having less than 60% of the median income. So you can see that obviously some of these things like poverty, but also things like income volatility, so how stable or unstable someone's income is, are very clearly related to income as a more general concept. And this is before we get into the kind of better known issues of confounders and effect heterogeneity and so forth that people often immediately think about. So I wanted to flag up all those challenges, if you like, of trying to study income before getting to a probably slightly more methodologically fraught study than maybe a systematic review of more longitudinal income change and mental health studies, which is an MR study. So one of our PhD students, Eric Eaglestrom, has done some excellent work looking at doing two-sample MR, where we're using a GWAS for self-reported household income and then a range of different health outcomes, including mental health outcomes like depression and so forth. And we also had a falsification outcome of childhood asthma. So what on earth is this type of MR study getting at there? I think that's probably a reasonable kind of critique. So we're kind of viewing this particular analysis with a healthy or unhealthy kind of dose of salt, as it were. But what did we actually end up finding? So we found that the MR results seem to suggest an effect of income on depression and probably on anxiety and so forth, not on childhood asthma, which is what you would hope for with a falsification outcome. So these results seem at least reasonably plausible, but also probably more usefully fairly comparable to the more conventional observational and natural experiment studies. But if the results had shown something very different, to be honest, I'm not too sure how much weight we could have given to them. Now, of course, there are a whole range of other causal approaches that often we need to try to use when we're studying things that can't be randomized, and especially things like the economic and social determinants of health. Often a lot of these approaches are kind of bundled up under the idea of causal epidemiology. It's important to note that while they attempt to give you a causal estimate, they are still subject to very strong assumptions of having measured your confounders and correctly address those confounders within the analysis. So provided we believe that, then these types of methods can give you slightly more causal estimates. So what were we interested in doing? Well, so again, going back to this issue of, well, what's the effect of income on mental health, but also starting to broaden it to think about, well, what's the effect of unemployment on mental health as well. So as you often do with a lot of the more causal epidemiological approaches, we started by drawing a causal diagram or a DAG, a directed acyclic graph. So you can see a slightly simplified version here. And we were interested in trying to understand the effects of both unemployment and poverty more specifically in terms of income. And to do this, we used data from the UK Household Longitudinal Study, also called Understanding Society, and we assessed these two different exposures, as well as trying to assess the extent to which income potentially mediates the effects of unemployment. And we were looking at poor mental health as assessed by the General Health Questionnaire, which is quite a commonly used measure of probable anxiety or depression, and included a range of confounders within a marginal structural model. I'm not going to get into the details of marginal structural modeling, but basically the fundamental idea is that you use observed variables to create inverse probability of treatment weights to try to create exchangeable exposure groups. So, and this particular approach allows you to address both time variant confounding, but also allows you to do mediation analysis. So that's why we were using it in this situation. So what does this type of method allow you to do? Well, these graphs show you the standardized mean differences before and after applying weights. And what you can see is that when you compare, for example, people who are in poverty and not in poverty, before using the weights, the groups are really quite different. And that's probably not too surprising. When we then try and apply our weights, our groups then become much more comparable with the light blue dots, indicating the standardized mean differences between the groups are much smaller. Of course, going back to the point I was making earlier, this is showing we're doing probably a decent job of addressing our observed confounders, but there remains the risk of there being important unobserved variables that we're not able to include in the analysis. So what kinds of results did we see? Well, so we saw, again, these are percentage points differences in prevalence between the exposed and unexposed groups. And you can see that probably the key take home here is there did again seem to be an effect of poverty on mental health. Again, probably smaller than maybe the more naive analyses might have implied. And the other thing to kind of note is that the effects of unemployment on mental health seem to be quite a bit bigger than the effects of poverty. And then when we did a mediation analysis, what we saw was actually that differences in income only seem to account for a relatively small proportion, so kind of 14% or so of the effects of unemployment on mental health. So overall then, what I'd probably conclude from that little kind of whistle-stop tour of trying to take a slightly more causal approach to the question of the effects of income on mental health is that there does seem to be an effect. It's much bigger for poverty, and it's much bigger again in terms of the effects of unemployment on mental health. So on to the next kind of more causal question we were interested in. So this is about income inequality. So you may have heard about the idea that living in a more equal society might be better for everyone's health. So actually, it's not just addressing poverty that matters or addressing low income. It's also, we might need to be worried about extreme wealth as well, and extreme levels of income. So this is a very kind of influential idea, and it's often debated the extent to which there's genuinely a causal effect of income inequality on health. Now, given there's been a lot of evidence in this area, we felt that it would be an appropriate thing to try and do a systematic review of. And there have been some a few decades ago, prior to our more recent one. However, the systematic review methods, at least our view of them, was that they've often focused on trying to synthesize evidence from randomized trials, where the point of the synthesis is often to improve statistical power. One of the arguments we've been making is actually there might be the potential to use evidence synthesis to try to improve our assessments of causality, especially when you have a lot of non-randomized studies where there might be different forms of evidence that allow you to be more certain about causality, that's not actually just reliant on statistical power. It might be that different study designs have different underpinning assumptions and therefore might allow you to be more confident in making causal conclusions. So to do this, Michal Shimonovich has been doing some excellent work where she's kind of looked back at the Bradford Hill viewpoints, or criteria as they're sometimes called, and then thought about how relevant some of those are in terms of assessing causality today in light of advances in causal epidemiology and in light of a methodological review of causal systematic reviews. So other people often try and apply systematic reviews to assess causal questions. When we did a methodological review, they generally, general practice is the reviews tend to be, so-called causal reviews tend not to be particularly systematic and often take quite an arbitrary and ad hoc approach to trying to make causal claims. So there's no real transparency in how typically they apply Bradford Hill. So we were also trying to use this idea of studying income inequality in health as an exemplar systematic view to try to do some methods development. So how did we get on? Well, firstly, we tried to go back to Bradford Hill's classic work and thought about, well, what are the implications of those viewpoints in light of more recent advances in causal thinking? So things like thinking about what DAGs might you draw in relation to the different viewpoints, how might grade, which is an approach used to assess certainty of evidence within systematic reviews, how might these types of things lead to you re-evaluating the viewpoints? To give you a slightly more concrete example, so for example, in the case of specificity, the original articulation within Bradford Hill's work was around associations being limited to kind of specific groups where you might expect the effects that occur and not seeing associations in other situations and so forth. So we thought that that way of thinking probably aligns to the idea of falsification outcomes or negative control outcomes and exposures. So perhaps maybe that's a more useful way of thinking about it today. So we then tried to figure out, well, how do we try to apply our kind of slightly updated or versions of Bradford Hill in the context of a more causal systematic review? And so we drew on an approach called process tracing that's often used within more mixed methods and qualitative research to try to create causal claims. And that approach involves thinking about two different dimensions in terms of specific bits of evidence. So we can think of evidence being highly unique in that it provides a strong signal that the causal claim is true. So in other words, it helps confirm your hypothesis. Or you can think of evidence as being highly definitive in that if you don't observe it, it's a strong indication that the causal claim is false. So to give you an example of that, something that might be highly definitive but have low uniqueness could be temporality. So if you don't observe temporality, so you observe that there isn't a temporal relationship, then that's probably quite a strong indication that it's not a cause and effect relationship. Now, the type of evidence that might give you the greatest confidence, both in terms of uniqueness and definitiveness, we've kind of suggested would be experiments. But you can see that lots of other aspects of Bradford Hill's work would actually be potentially still quite informative, both in terms of helping you confirm a hypothesis, but also potentially trying to disprove it as well. So when we did our systematic review, we did the kind of more usual type of things. So we've done a systematic review and meta-analysis of income inequality and self-rated health, as well as all-cause mortality. Had an even huger number of articles to screen this time. And there really is quite a lot of evidence out there already. So a good 2.9 million participants within the meta-analysis of on self-rated health and 10.7 million on all-cause mortality. But still low and very low certainty when assessed using grade. And you can also see there's very small effect sizes that were observed within the meta-analysis as well. So we then applied these principles from process tracing and thought about, well, how valuable was some of this evidence in terms of making a causal conclusion. And that helped us understand, right, there are certain areas where actually the evidence is much more lacking for causality. So I think in terms of this, the substantive question of income inequality and does it cause poor health, and at least in terms of self-rated health and all-cause mortality, at best, it's very weakly associated, and the evidence for causality is certainly lacking. So at the moment, we don't have the evidence to either disprove it or to prove it, but there's certainly no clear evidence for there being a strong causal relationship. This also is potentially informative for some of the policy modelling that we'll come on to now. So if you can ever be confident of causality, or at least confident enough to think about policy implications of the work you're doing, then simulation modeling might be a nice way of trying to think about impacts on policy under different policy scenarios. And ideally, you might work with policymakers to try to create these. So my first kind of foray into policy modeling was more as someone analyzing policy. And at the time I was working on minimum unit pricing of alcohol, and there was a very influential modeling study done by Sheffield University, the Sheffield Alcohol Policy Model, which basically was a really important piece of evidence in leading to the Scottish government in implementing minimum unit pricing. And the interesting thing about it was that a lot of policymakers and researchers that I spoke to would emphasize the importance of this type of modeling study, especially in situations when you'll think about things that can't be randomized, but you do still want to reduce the extent of uncertainty you have before you make a decision. So it may not be as good as the the gold standard, but it certainly does help reduce uncertainty when making policy decisions. So I'm going to give you 3 examples of when we've done some modeling from the very simplistic, which is the first example, to some slightly more nuanced approaches and slightly more complicated approaches. So we were interested in the cost of living crisis. So obviously that was driven by lots of different things, including, for example, a very bold budget from Liz Truss previously, but also kind of broader external factors, which has led to a kind of a stagnating wages and benefits for quite some time. And all of these things are likely to have important implications on health. So we were interested more specifically in one particular aspect of this, so the energy price cap. So you might remember from a year and a half ago or so, big concerns about the very rapidly increasing costs of paying for energy. So we tried to use we used an existing static tax benefit microsimulation model, so something called UKMod. What that does is it takes a representative survey of individuals and it looks at how people might be affected in terms of their level of income and their level of poverty under different scenarios. So we looked at what would happen if there was no policy response, what might happen under the kind of support that the government then ended up introducing. And we applied the effect sizes from that previous systematic review and other systematic reviews to see, well, what might then be the implications on mental health. So this is common mental disorders, so probable anxiety and or depression. And you can see that without a policy response, you'd expect there to be an additional over 500,000 additional people with poor mental health, where in terms of adults, whereas with the target support and the price cap, the increase we expect to be much more like 92,000. So really potentially quite substantial mental health benefits there. Importantly, I'm not commenting here at all on whether the actual mechanism that the government implemented was necessarily the right one. So there were potential alternatives such as very rapid insulation schemes, which could have been arguably achieve the same benefits, but in an ongoing way, and might have climate benefits as well. So onto the maybe slightly more advanced approaches that we might use. So this is a schematic illustration of the SIMPATHs microsimulation model. So this has been developed with colleagues at Essex, and basically it involves taking a representative population of the UK, transitioning them forward in 1 yearly increments, and each person experiences a number of different processes that they go through. So they age, they might change their education level, they might change their health, they might change their household composition and might get a new partner or not, and they might then earn some money through their wealth, and they might then either work or not work and work a certain number of hours, and all these things then might influence whether people receive benefits, and all of that then might influence people's mental health, and then we go on to the next time period. So there's a set of processes that we're applying to a representative set of households and individuals. So we know which individuals live in which households over time. So again, we're using largely understanding society, but some additional data sources as well to create our population. So this is an example of what's called a discrete time dynamic microsimulation. The modeling allows for there to be what's called a labor response. So I won't get into the nuances of the economics here, but basically, if you give people more money, then the economists would argue that then might disincentivize the number of hours that people work. Similarly, if people are likely to actually be paid better, they might be more likely to move into work and so forth. We've done quite an extensive set of validations, looking at, for example, how well the model aligns with historical data when we run the model from an earlier timeline. And we incorporate uncertainty both in terms of between people, but also in terms of the effect sizes that we're including into the modeling. So, for example, if we're not very sure about the exact effect of income on mental health, we sample from a distribution within the modeling. So to give you a bit of a couple of examples of using this model, so we can go back the way and try to understand what has the impact been of certain policies that were really implemented. So taking you back to the start of the pandemic and when we first experienced lockdown, you might there was concerns about the potential economic consequences in terms of leading to unemployment, but also potentially loss of income and so forth. And so Rishi Sunak, back when he was Chancellor, introduced arguably quite a generous package of provisions to keep people in work, so the furlough scheme, but also increasing benefits in terms of the most notably the £20 uplift to universal credit. Oops, wrong way. There we go. So what do we think all of that did? Well, so when we run our simulation model, we think that if we didn't have the COVID policies, we would have seen a substantial fall in the employment rate, so increased numbers of unemployed people, and an increase in poverty, which was substantially mitigated by the economic response. And that then probably translates to a reduction of about 2 percentage points in prevalence of common mental disorders. Now, although in terms of prevalence, that may not sound like a lot, that still does equate to about averting over 1 million likely cases of anxiety or depression. So still potentially important. And then a second example of how we might use this type of modeling is universal basic income. So this is a policy that's often widely discussed, but is nevertheless very radical. So the idea is to give everyone within a society an unconditional and regular payment in cash. Now, it's never really been implemented in a high-income country in this way, and it's very difficult to actually do a trial of, and even trying to do a pilot has proved challenging. So there have been a few attempts at trying to introduce a pilot, none of which have really progressed. So this is maybe a good example of exploring what the implications might be through policy modeling, because it's something that actually would be very difficult to try out in the real world. So we looked at 3 different UBI scenarios. So we looked at a UBI scenario, which is what we've called a partial UBI, where everyone gets the same amount of money as existing unemployment benefits, with some retention of means tested benefits. So additional money that's often given for example, to people with disability. We had a second scenario called full UBI, which is the idea of giving everyone enough money to actually live a healthy life. So that's referred to as the minimum income standard, and then what we've called a full plus scenario. So for some people, even the minimum income standard may not be enough money. So for example, if you have additional needs due to a disability, you might well need to get a top up beyond what a UBI would provide. So if you've got extra costs for housing, transport, etc., due to a disability, for example. So interestingly, one of the advantages that's often argued about UBI is that you could abolish means testing, but that is actually in practice quite difficult to do. So we ran a range of analyses. One thing that you're probably noticing about a lot of these modeling studies is that so far we've been sticking to relatively short timescales. One of the reasons for that is because we're not currently able to incorporate macroeconomic effects. So, for example, if a policy was to increase or reduce economic growth, but that's something we're working on incorporating going forward. We've also done a couple of more structural sensitivity analyses where we've allowed for different types of employment effects. So often it's assumed by economists that if you introduce a UBI, a lot of people might stop working, whereas other people would say, no, that's not what we would expect to happen. There's also the potential for the effects of unemployment to be quite different in a world with UBI rather than nowadays. And then we've also used a range of alternative effect estimates for some of our key variables as well. So the main thing to take away from this slide is that UBIs are very, very expensive. So in the orders of £1 trillion type thing. So massively, massively expensive. It's also worth noting that actually often UBIs do not necessarily benefit the poorest in society because many of the poorest in society already receive benefits. So they are particularly good often, especially under the partial scenario, for middle income earners. So what does a UBI do to poverty and to employment? Well, so a UBI would probably markedly reduce poverty under a partial UBI scheme, but pretty much abolish it under a full UBI scheme. And there are some fairly small effects on employment, but because the effects on employment matter so much for health, they end up potentially being quite important in terms of mental health. So the effects on mental health could be a potential increase of 150,000 more cases of probable anxiety or depression if we believe that people stop working, and stopping working has a similar adverse effect on mental health as it does today, or it could lead to around 100,000 fewer cases if there's no change in people's employment. Interestingly, there weren't large effects on inequalities. So the advantage of this type of modeling is that we can really explore lots of different axes of inequality. So we can stratify our results pretty much by any variable that's within the model, as well as being able to look at intersections across inequalities. So just a last quick slide to flag up, although we do have this interest in modeling, that doesn't downgrade the importance of actually evaluating policy that's being implemented. So we are and continue to still be very interested in evaluating the effects of policies that are genuinely implemented. So, for example, we're currently evaluating the effects of universal credit on mental health. And similarly, we've looked at kind of similar schemes and and kind of poverty alleviation schemes in other countries, such as using the 100 million cohort in Brazil. And just to flag up that there will be an updated version of the MRC guidance on natural experiment studies a bit later this year. So to wind up, hopefully I've kind of convinced you that the economic determinants of health are important and arguably pretty important for health inequalities. Understanding them is very challenging, not only in terms of get at causality, but also in terms of conceptualizing them and so forth. Hopefully I'll have got you to think a bit more about the role of evidence synthesis, and perhaps we can maybe do things in addition to just meta-analysis that might help us make firmer causal conclusions. And I've hopefully tried to illustrate the value of policy modeling for research purposes and informing policy. Obviously, a whole range of funders that I'd like to thank as well. So hopefully I've stuck to time, which should give us a bit of time for questions.
Thank you so much, Vittal. That was really, really interesting. I will keep an eye on the chat online, but yeah, thank you so much. I feel like we'd normally give a round of applause, but yeah, that's really interesting, and it's great to see all the different sort of simulation models you've got going as well. I've not seen that sort of thing before. Did anyone have any questions in the room? I've got a quick one while people are thinking. I was just wondering how much you think sort of how parental income when people are children impacts the sorts of things you're looking at with mental health and income as an adult, and how much of that might be explained by sort of childhood factors.
Yes, that's a great question. So I've focused mostly there in the talk on adult income, partly because it's much easier. And so that's what we've started with, although I would say that's kind of a relative statement in that it's not necessarily easy to look at, but it's still quite a bit easier than within childhood. I'd say the evidence for the effects of child poverty on health is probably much stronger than it is in adults. But you have the added complication of kind of life course effects, as it were. So there are probably going to be immediate impacts on health and potentially longer term impacts on health. So we do actually have a public health registrar who's just starting their PhD in a couple of months, looking at life course effects of child poverty on different health outcomes, including on kind of adult health, and they, as well as some other projects, are going to be working on trying to incorporate some of these child poverty effects into our microsimulation modeling. So then being able to say, for example, what the effects of different benefits policies and so forth might then be on longer term health outcomes of children nowadays, but also of future generations of adults, as it were. So that's another important reason why we've not gone into longer term policy modeling just yet. It's been only a few years that we've been looking at in terms of the modeling, is because actually some of these effects of on people who are currently children but are future adults could be quite large.
Yeah, that's really interesting. We'll keep an eye out for that. We've got a question in the room. Do you want to try asking, then if you can't hear Vittal, let me know. I'll repeat it.
Yeah, okay. I'll try to speak loudly and clearly. Firstly, thanks. That was fascinating. Yeah, I mean, so one thing I was wondering about the microsimulation models, and this may be an annoying thing to add to your list of things which you haven't yet worked out how to incorporate. But yeah, you were talking about how in a world with UBI, the experience of unemployment would be quite different, which, yeah, makes a lot of sense. But presumably also the experience of employment would be quite different, right? Because in the same way that in contexts where there's greater trade union coverage. Basically, jobs are less crappy because people have more bargaining power to keep conditions a bit better or make conditions a bit better. And presumably, if people were more underwritten in terms of basic welfare by UBI, then jobs would be, if you want people to come and work for you and they're not facing destitution otherwise, jobs would also be better. So I think that's an extra added complication that, I don't know, maybe needs to go in there.
Yeah. So that's certainly something that's kind of debated. It's something that we did actually explore a little bit within some of our kind of sensitivity analyses. The reality is, so that there, as I mentioned, there haven't been kind of UBIs implemented in quite this way within high income countries, but there have been other things that have been introduced that have some, but not all of the features of the UBI. And so it is possible to look at what happened in those kinds of examples. The idea of kind of improved bargaining power, it's often raised. It's not totally clear that it's definitely happened, as it were. What has happened has been maybe greater investments in things like education, for example. So people might, instead of working in low-paid jobs, they might get a degree or something like that, for example. But we can, the advantage, I suppose, of a modeling approach is we can try to take a kind of a plausible assumption of what might the impacts of any kinds of improvements to work conditions be, and then try to do a kind of what if scenario and explore what might happen. In reality, I suspect it probably wouldn't lead to kind of massive improvements in health even then.
Cool, thank you.
Any other questions? If anyone's got any online, please do. I think you can raise your hand or post a question in the Q&A. Keep an eye. Anything in the room? Oh, we have got a raised hand. Yeah, Janine, do you want to ask?
Yeah. Hello. Thank you very much for your talk. It's really thought-provoking. And I'm just thinking in terms of like you talking about meta-analysis and evidence synthesis. And I also been like working on an example to demonstrate triangulation. And I've also had the same thing of everybody seems to have measured different, potentially similar outcomes, but not quite measured the same way. I don't know whether you've looked at potentially incorporating the meta-analysis with kind of risk of bias assessment potentially. And just at the end of the day, like the results you get is as good as your data, I suppose, to highlight that. I don't know, any comments on that? Be great.
Yeah, absolutely. So we did look at kind of risk of bias assessments to some extent. Generally the very simplest thing to do is just to stratify by risk of bias, and actually we kind of saw pretty similar effects by risk bias. So that's the very simple thing that everyone does. Now, but as you're getting at, you can try to look at instead things like the e-value and so forth, which in the context of meta-analysis that I think Van der Weel and others have kind of suggested previously. Now, I suppose the downside I would say here is that, or at least maybe the argument I'm trying to make here is that perhaps we should be slightly more nuanced than just thinking, right, there are better quality studies and worse quality studies, and instead maybe ask the question, are there studies that are subject to different underpinning assumptions, and do those, and that I suppose is pushing you much more in the direction of triangulation. So if you have studies, for example, where there's been a few natural experiment studies, but they're limited in terms of sample size, for example, and then you have much more traditional observational studies that are massive, but are more subject to bias. And you might have, for example, a couple of trials, but they are done in very atypical situations, and they all point you in the same direction. Can we get at a more transparent way of bringing all that together? So I'd say that's hopefully trying to move a bit beyond the just doing the kind of assessment of risk of bias, which often ends up being quite a unidimensional kind of scale of these studies are at more risk of bias and these studies are less risk of bias.
Okay, thank you.
We've probably got time for one more question, if anyone has anything. No? Okay, well, if not, then yeah, thank you so much again, Vittal. It's really lovely to have you speak with us. Yeah, great. Thank you.
Great. Well, thanks very much, everyone. And once again, apologies for not being able to make it in person. Afraid just with other travel and so forth, it just couldn't work out. But hopefully I'll get to be able to meet some of you in person at some point in the future.
Great. Well done. Thank you.